Today, we're presenting on our work to support COVID-19 patient management with data and how we stood up a clinical data science team to get answers to clinical questions in 2 weeks. My name is Allison Callahan. I'm a research scientist, and I'm co-presenting with Jose Posada as part of the data science team for IAT. The work that we're presenting today was a team effort comprised of the people on this slide. So to set the context, at the beginning of January, the Stanford Hospital was experiencing a COVID surge of patients and had an interest in using practice-based evidence to guide how we responded to that surge. Fast-paced changes in patient care needs call for quick and informed decision-making, and one of the key challenges during this surge was how to safely manage and discharge patients in order to maintain and preserve hospital capacity. Evidence was needed to assess whether it was safe to discharge patients on home oxygen instead of keeping them in the hospital, how to manage patients with high flow oxygen on the floor, and how to risk stratify for complications related to COVID.
To answer those questions, we use a process when we formalize those broad questions into very actionable ones. We define cohorts, we pull data from our clinical research data warehouse. We did an iterative process with the domain experts. With the data we had, we conduct the analysis, and we share these results with our internal and external stakeholders.
So we used this process to tackle 4 questions so far, and we're going to present the results of the second, which was amongst adult COVID positive patients with high oxygen needs, what is the rate of transfer to the ICU? And what is the rate of intubation or mechanical ventilation amongst those patients? The first part of the process was to translate that question into a detailed formulation. So in this case, our formulation was among adult patients, that is people who are at least 18 years old, who are admitted with a COVID-19 diagnosis or had a positive SARS-CoV-2 test within 2 weeks of their date of admission or during their stay, and who did not have a do not resuscitate order and are high oxygen, that is received at least 6 liters per minute of oxygen at any time. How many such patients were transferred to the ICU? And how many of those patients were intubated and placed on mechanical ventilation?
To start collecting the variables to create the cohorts, we started from our 2 main sources of data, where we start OMOP database and our SHC Clarity database, where we, with a merge set of data, we define which variables were better to get from each one of those databases by linking the data from those 2 databases by a unique patient identifier. For STAR OMOP, we went in to get the login code for the SARS-CoV-2 test, the visit classifications, and the flow sheets. And from SHC Clarity, we get the do not resuscitate orders that are usually patients that do not want to get intubated or resuscitated, and when and where the mechanical ventilation was happening for those patients. The merged data set was then used to create all the cohorts.
The results of the analyses we conducted using the data from the STAR data lake indicated that only about 14% of patients meeting the definition of high oxygen need ended up intubated and placed on mechanical ventilation. And the interpretation of this by the clinical experts on our team were that because of that relatively low percentage, the threshold for ICU transfer being 6 liters per minute of oxygen or higher may be relaxed if ICU capacity is constrained in the future. So this was the result for one of these 4 questions. And in answering it, we identified a number of challenges in our process.
Among those challenges, we identified patients that had a COVID diagnosis to justify for their testing. Then we really needed to use the infrastructure that provides us with enough capacity to process billions of records for this high frequency data. Then putting this relevant information and contrasting and being able to use the expertise to clean out implausible records and tracking down and managing these anomalies that happen because of the nature of the data and being able to refine and clean.
The takeaways from our findings were that data summaries are helpful in such settings, independent of statistical analyses that you conduct in addition. And importantly, 80% of the effort in this 2-week period where we answered these 4 questions was in getting the data pulls done. And this is where we had to work really closely with Jose and Gomez to make sure they were done correctly. The analyses following these polls were the easy part. And collectively, we spent about 300 hours in a very short period of time. And this was an amazing collaboration and communication that relied on the diversity of skills of our team and willingness to participate in long working calls and Slack. Lastly, as Jose indicated, the use of STAR OMOP and Clarity data together in the STAR data lake were essential to our being able to answer these clinical questions. So this is all that we have. If you have further questions about this work or the other questions that we answered, please let us know. Thank you.